Hello friends, today we are going to discuss the abdominal compartment syndrome, and this was a question which was asked in DRNB critical care exam in December 2022. The question was abdominal compartment syndrome in acute pancreatitis. So in critically ill patient, intra-abdominal hypertension and abdominal compartment syndrome frequently manifest as consequences of intervention such as intubation and fluid resuscitation. 25% of patients in the intensive care unit are affected by this condition. Moreover, the previous studies indicated that over half of these patients encountered intra-abdominal hypertension within few weeks of their ICU admission. So, if this is the case, then timely diagnosis of intra-abdominal hypertension is crucial. If overlooked, intra-abdominal hypertension can evolve into abdominal compartment syndrome, which could subsequently result into organ dysfunction. This progression significantly affects the prognosis of critically ill patients. So, the Rentam Blaster et al. Reported that during initial 2 weeks of ICU admission, the presence and severity of intra-abdominal hypertension independently elevated both 28 and 90-day mortality, with mortality surging to 38.6% when abdominal compartment syndrome manifested. Recognizing the ACS early based on the clinical indicators and risk factors can dramatically decrease the associated complications and mortality rate. So timely detection of these clinical signs allow for immediate emergency laparotomy to relieve the pressure. However, in practical clinical setting, measuring intra-abdominal pressure in critically ill patient presents the challenges. Although intra-abdominal pressure frequency has decreased, the deterioration due to intra-abdominal pressure still occurs in approximately 3% to 5% of patients. In 2013, the World Society of Abdominal Syndrome published the updated consequences definitions and the clinical practice guideline for intra-abdominal hypertension and abdominal compartment syndrome. Since then, intra-abdominal hypertension and ACS treatment have been developed and revised based on these guidelines. Based on these guidelines, we provide further insight into early detection, preventive therapeutic measures, and definitive treatment when these conditions manifest. So, pathophysiology. In individual without pathological condition, intra-abdominal pressure is zero. During standard respiratory function, positive pressure ventilation exert direct impact on the intra-abdominal pressure. So the baseline intra-abdominal pressure is 5 mmHg, but certain conditions, including coughing, obesity, pregnancy, elevates the baseline pressure. Notably, the factor that increases intra-abdominal pressure can be categorized into 5 distinct groups. The elasticity of abdominal wall and diaphragm, increase intraluminal content, increase intra-abdominal content, systemic condition causing capillary leak and fluid resuscitation, and underlying causes. So the compliance is forcibly restricted by mechanical ventilation, resulting in an intra-abdominal pressure nearly double that of the patient with spontaneous breathing. Additionally, among the intra-abdominal organ, the movable wall area is confined to abdominal wall and diaphragm. The elasticity of the abdominal region is notably reduced and compromised after surgical intervention, in which there is reduction in intra-abdominal volume domain, which could significantly influence its effect. Within intra-abdominal compartment, the viscera plays the predominant role in influencing pressure dynamics. So these are the risk factors for intra-abdominal hypertension and abdominal compartment syndrome by category with associated references. Elasticity of abdominal wall and diaphragm. So risk factor is abdominal surgery, major trauma, major burns, prone positioning, and high pain. Then increase intraluminal content. The risk factors is gastroparesis, gastric distension, ileus, colonic obstruction, and volvulus. Then increase abdominal content is caused because of the acute pancreatitis, distended abdomen, hemoperitoneum or intraperitoneal fluid collection, intra-abdominal infection, abscess, intra-abdominal and retroperitoneal mass, laparoscopy with excessive insufflation pressure, liver cirrhosis with ascites, and peritoneal dialysis. Then systemic condition due to capillary leak. It occurs because of acidosis, massive fluid resuscitation and massive transfusion, extracorporeal membrane oxygenation, sepsis. And underlying cause, it occurs, the risk factors are head elevation state in bed, obesity, peritonitis, and pregnancy. The dimensions of bowel coupled with the volume of intraluminal content can significantly affect the pressure. Intervention during resuscitation, particularly extensive fluid resuscitation, can cause capillary leakage. This, in conjugation with the fluid resuscitation induced systemic alteration, can contribute to the escalation in IF. Considering potential underlying etiologies is imperative. In patient presenting with elevated IAP attributable to underlying etiology, there is inherited predisposition towards development of ACEs. Now about diagnosis, monitoring of intraabdominal pressure is crucial for detecting the risk of abdominal compartment syndrome escalation. In patient undergoing treatment, early signs of intra-abdominal hypertension should be identified using intra-abdominal pressure measurement before this sign manifests as organ failure and other symptoms. Although intra-abdominal hypertension grading is not an absolute criteria, higher intra-abdominal hypertension grades are associated with higher mortality rate. In addition to IAP monitoring, early recognition of abdominal compartment syndrome through clinical signs and risk factors can significantly reduce the associated morbidity and mortality rate. Therefore, intra-abdominal pressure monitoring is essential for ICU patients with risk factors. So, regarding measurement, bladder pressure measurement is the straightforward and minimally invasive technique for reliably estimating intra-abdominal pressure. This method relies on the principle that changes in the intra-abdominal pressure are reflected in intravesical pressure. So, as 90% of patients in the ICU are equipped with the Foley's catheter, this allows for convenient measurement directly during Foley's insertion without need for an additional invasive procedure. So, intra-abdominal pressure is recorded in mmH. Care should be taken to avoid measurement during moments when IAP may actually increase due to actions such as sneezing, coughing, shouting, and performing Valsalva maneuver. So measurement should be made at the end of expiration with the patient in supine position. The transducer need to be zeroed at the level of mid-axillary line and patient need to be free from abdominal muscle contraction caused by conditions such as peritonitis. Understanding the definition of abdominal compartment syndrome does not rely solely on absolute values of IAP, it's crucial. Instead, the diagnosis of intra-abdominal hypertension should always be considered in conjunction with potential for new organ dysfunction. Even if patient with intra-abdominal hypertension exhibit the same intra-abdominal pressure level, the risk of abdominal compartment syndrome can vary significantly owing to individual variables such as blood pressure and abdominal wall complaints. Factors such as pregnancy, cirrhosis with ascites, severe obesity can influence abdominal wall compliance and consequently the likelihood of abdominal compartment syndrome. Abdominal perfusion pressure has been proposed as more accurate predictive variable of visceral perfusion and better endpoint for resuscitation than either intra-abdominal pressure and mean arterial pressure alone. So abdominal perfusion pressure is the value obtained by subtracting intra-abdominal pressure from mean arterial pressure. However, although there is evidence suggesting that abdominal perfusion pressure may be more accurate predictor of visceral perfusion and potentially better endpoint for resuscitation than intra-abdominal pressure or MAP alone, relevant randomized controlled trial or meta-analysis supporting this view conclusively are lacking. So the observational studies available are predominantly of low quality due to bias and indirectness and mainly involve heterogeneous population of ICU patients. These studies suggest that reduced abdominal perfusion pressure may be poor independent prognostic factor, but the effect of intervention to improve abdominal perfusion pressure on clinical outcome are unclear. Therefore, World Society of Abdominal Compartment Syndrome withheld the recommendation on the use of abdominal perfusion pressure in managing critically ill or injured patients until further quality intervention trials are conducted factor, but the effect of intervention to improve abdominal perfusion pressure on clinical outcomes are unclear. Therefore, World Society of Abdominal Compartment Syndrome withheld the recommendation on use of abdominal perfusion pressure in managing critically ill or injured patients until high quality interventional trials are conducted. So this is the diagram which is a representative of the grades of intra-abdominal pressure. So if there is a sustained rise in intra-abdominal pressure of more than 12 mmHg, we can label it as intra-abdominal hypertension. So if it is grade 1, then the intra-abdominal pressure is between 12 to 15. Grade 2 means intra-abdominal pressure lies between 60 to 20. Grade 3 when intra-abdominal pressure is between 21 to 25. And grade 4 when intra-abdominal pressure is more than 20. Now the primary intra-abdominal hypertension and abdominal compartment syndrome. Definition of the primary, secondary and recurrent IH will discuss here. So these typically arise from primaries arise from the direct abdominal trauma, abdominal surgery, mass-like lesion, and other causes of ascites. Secondary IH and the ACS originate from the non-abdominal and non-pelvic sources such as massive flow resuscitation, major burns, or elevated IAP due to sepsis. And the recurrent IH and the ACS refers to the re-emergence of elevated IAP after treatment in any given situation. Now, this is the diagrammatic representation of primary, secondary, and recurrent intra-abdominal hypertension. So, as I mentioned, this primary is mainly because of the primary abdominal pathology. Secondary is not originating from the abdominal pelvic region, but outside of it. And the recurrent is redevelopment after previous surgical or medical. So, IH assessment, although the cause of increased IH can be categorized into four distinct groups, noting that elevated IAP is rarely caused by a single factor is important, considering that multiple factors often interact in a complex manner. Considering their multifaceted nature when developing treatment plan is essential. Now the progression of IH into ACS and its impact on various organs. An increase in IAP can lead to IH and ACS, both of which can result in organ failure. This can manifest as a cause of the consequences. Extensive research is currently underway to understand the far-searching effect of elevated IAP. Isolated and transient elevation in intra-abdominal pressure is seldom associated with significant organ failure in patients. So persistent IH can progress to organ failure. AC abdominal compartment syndrome is characterized by onset of organ dysfunction due to sustained increase in intra-abdominal pressure. ICU patient with intra-abdominal hypertension commonly transition to multi-organ dysfunction not solely from elevated IAP but also from other concurrent factors such as sepsis. Therefore, monitoring IAP consistently to determine intra-abdominal hypertension persistence is essential. Distinguishing between organ dysfunction caused by IH and that from the other cause is crucial. Multi-organ dysfunction resulting from the ACS progression at an alarming rapid rate. However, the prompt resolution of the ACS offers an opportunity to reverse this catastrophic outcome. In critically ill patients, rigorous and continuous monitoring of the IAP is necessary to predict potential organ dysfunction, which is attributable to intra-abdominal hypertension. Now, impact on kidney. Although abdominal compartment syndrome affect the multiple organs, kidney are the most commonly affected organ. This is largely because changes in the kidney function are readily reflected as a decrease in the urine. Most initial treatment for acute injury involves aggressive volume replacement, which significantly contribute to elevated iron. Then impact on the respiratory system. The respiratory system is significantly affected. The intra-abdominal hypertension induces the decrease in the lung volume, uh, which further impair thoracic wall components. Additionally, independent risk factors for ventilator-associated pneumonia were identified. So, Papa Crioli et al. Found that bacterial strain detected in patients with ventilator-associated pneumonia and intra-abdominal hypertension were predominantly intestinal flora, Klebsiella, Proteus mirabilis, and E. coli. In contrast, in patients with ventilator-associated pneumonia and normal intra-abdominal pressure, Pseudomonas acinetobacter and Staphylococcus aureus were mainly detected. This suggests the possibility of bacterial translocation in patients with intra-abdominal hypertension. Now, impact on circulation. So, intra-abdominal hypertension significantly affects hemodynamics. An increase in intra-abdominal pressure elevates intrathoracic pressure and impedes the venous return from the inferior vena. Additionally, increase in abdominal pressure inherently increases afterload, resulting in decrease in stroke volume. This leads to increase in the end diastolic pressure, which in turn diminishes cardiac failure. The outcome is reduction in systemic cardiac output, manifesting as decreased blood pressure and impaired circulation. Now the impact on intracranial pressure. Intra-abdominal hypertension reduces the backflow of venous plexus into spinal cord. An increase in intrathoracic pressure elevates the central venous pressure, leading to the diminished venous circulation through jugular vein. This increases intracranial pressure. Now the impact on gastrointestinal tract and hepatobiliary system. Function of the intestine and the liver are also affected by intra-abdominal hypertension. An increase in abdominal pressure directly affects intestine, reducing the splanchnic perfusion. Consequently, intestinal permeability increases, leading to the mucosal barrier failure. This can trigger bacterial translocation, potentially causing organ failure. Additionally, intra-abdominal hypertension leads to the decreased gastrointestinal motility. This reduces the motility, both a cause and the effect, can induce the conditions such as ileus, which can further exacerbate intra-abdominal hypertension. Effect on biliary system were also assessed. With the onset of intra-abdominal hypertension, there is significant reduction in the blood flow to portal vein and inferior vena cava along with increase in pressure. As a result of this sustained impact, cell damage and the reparative response can be observed in the liver. While organ failure can occur individually, they often manifest in the multi-organ fashion. Now regarding treatment and monitoring, periodic measurement of intra-abdominal pressure in patients at risk of abdominal compartment syndrome in the context of intra-abdominal hypertension is crucial. In addressing IAP monitoring for ICU patients, we suggest strategies with the nuance that account for presence and number of risk factors related to IH and the ACs. The WSACs does not universally mandate IAP monitoring for all ICU patients, but does stress its importance in those with identifiable risk factor for IH and ACs. So further, the World Society of Abdominal Compartment Syndrome does not recommend the use of trans-bladder method for accurate IP measurement and the protocolized approach to monitoring and management to enhance patient outcome. So they recommended that IP monitoring for any ICU patient showing at least one known risk factor for ACS. This is based on understanding that presence of single risk factor significantly increases the risk of ACS, thus necessitating early and careful monitoring. Furthermore, in patients with two or more risk factors, they recommended enhanced level of IAP monitoring. This is due to compounded risk from the multiple factor and demands a more comprehensive monitoring strategy for prompt detection and effective intervention. This proactive approach is vital to reduce the incidence and impact of this condition. Titration of medical treatment and intervention is paramount importance. The principle of this treatment is associated with five therapy categories that addresses the factor that increases IH. Recognizing the patient in early stage of low-grade IH allow for prevention and response to ACS through non-surgical treatment. However, regardless of grade, duration of intra-abdominal hypertension can directly affect patient's prognosis, especially when intra-abdominal hypertension with organ failure occur. Therefore, correction is crucial in this situation. Close observation during this process and verification of organ failure are vital. So, if abdominal pressure is more than 12 mmHg, monitor IIP every 6 to 8 hours. Close observation of the cause and the increased abdominal pressure and investigate for the organ failure. Titrate medical treatment and intervention. And if the patient is intra-abdominal pressure is not reduced, then go for decompressive approach. So first is elasticity of abdominal wall and diaphragm. The appropriate sedation and the analgesia may be beneficial for pain control. The efficacy of neuromuscular blockage in relation to elasticity of abdominal wall and diaphragm has been established. However, continuous use of neuromuscular blockage is the challenge. In dilated study, although neuromuscular blockage demonstrate temporary reduction in IAP, definitive result in improving patient urine output or survival rate were not achieved. Therefore, neuromuscular blockage should be considered for treatment as a bridge to decompressive laparoscopy. For patients with the burns, an hysterotomy has been confirmed to improve elasticity of abdominal wall and elevate abdominal compartment syndrome. During treatment, this procedure should be considered alongside the decompressive laparotomy. Then increase intra-abdominal and the intraluminal and the abdominal content. In patients with underlying disease or increased volume of intraperitoneal fluid due to fluid therapy, temporary relief from elevated abdominal pressure can be provided through methods such as percutaneous drainage before resorting to resuscitative laparoscopy. From the initial stage of such a non-invasive treatment, the recent addition of point-of-care ultrasonography to treat intra-abdominal hypertension is also crucial. The use of point-of-care ultrasonography for diagnostic and therapeutic approach can be holistically applied to intra-abdominal hypertension treatment. Then Pereira et al. Used this for initial treatment of patients with intra-abdominal hypertension and ACS. This procedure aided in adjusting the position of nasogastric tube in pyloric area to facilitate drainage and assessing bowel movement and need for further intervention such as enema. Percutaneous decompression can be considered by verifying amount of intra-abdominal fluid. Then systemic condition due to capillary leak or fluid resuscitation. By performing inferior vena cava and cardiac echography, the degree of fluid overload and cardiac function can be approached by adjusting the patient's fluid balance accordingly. World Society of Abdominal Syndrome Management algorithm recommended checking intraluminal content, verifying the degree of abdominal wall compliance improvement, and confirming renal, hepatic artery, and portal venous blood flow perfusion. Additionally, early venovenous hemofiltration reduces intra-abdominal pressure and diminishes the decline in organ function. Then the Chitha method demonstrated a significant elevation in IAP when subjects were in supine position compared to 30-degree head elevation. While study did not elucidate the impact of this measurement on organ failure beyond a simple increase in value, the finding did indicate that measurement taken other than supine position might not reflect the true values accurately. This suggests that there may be need to reevaluate IIP measurement when the head is elevated. Furthermore, in intra-abdominal hypertension, passive leg raising, which is used to anticipate patient's fluid response, can produce many false negatives. Therefore, verification and caution are needed when treating shock. Now, the last treatment is decompressive laparotomy. When ACS occur, the most definitive treatment method is decompressive laparotomy, which must not be delayed. An open abdomen may be therapeutic option. Uh, Among the rescue therapy method for open abdomen, negative wound therapy, which is commonly implemented, has been reported to have minimal impact on intra-abdominal pressure measure. Although surgical intervention remains the definitive solution for certain clinical conditions, many patients may not be hemodynamically stable for immediate surgery. The rapid restoration of systemic perfusion following one abdominal procedure is essential. However, prolonged maintenance of open abdomen can lead to postoperative complications. Furthermore, the resuscitation phase after open surgery does not always lead to immediate recovery. There may be instances in which extensive fluid resuscitation is required for certain period, leading to deliberations regarding the timing of abdominal closure. Nonetheless, one primary treatment goal is accomplished prompt closure of abdominal wall should be attempted because the potential complication and increased difficulty of future closure. However, care is needed as forcing facial closure can increase the risk of ACS recurrence. In some cases, abdomen may close while fascia is excluded. This can lead to herniation. Alternatively, subsequent surgery may be required. This could involve applying mesh or separation and suturing of the abdominal fascia along the midline to reconstruct the abdominal wall. Thank you, guys.